Oh, goodness. Okay, it's right at 12 o'clock, so we'll go ahead and get started. I'm going to stop sharing my screen. Welcome, everyone. Welcome back to part two with Dr. Coiner. We received so much love last time. You guys wanted us back. We had to come back with a part two. So I'm super excited. Are you excited, Dr. Coiner?
I'm excited. I was just trying to think of a movie that was better, like the redo, that was at least as good as the first. So think about what our goal is. Maybe Top Gun. Like I think Top Gun would be on the
Oh,
list. Like
yes.
first one was epic, second one like didn't disappoint. So we're gonna try to match that bar.
Yeah, we're not going to disappoint. Um, okay, just a few housekeeping items before we get started. Yes, this is part two, but if you did not see part one, you will not be behind at all. This is a Q&A, so you missed a ton of fun things, but you didn't miss anything that you would be confused today for part two. Second thing is, if you're in the audience, Dr. Coiner and I, we cannot see you and we cannot hear you. But if you have a question, please put it in the chat. Last time when we did this health talk, I also let people know that you can message me privately in the chat if you don't want to put your question for everyone to see, and I will respect your privacy. I'm trying to think of other little housekeeping items. Ask us in the chat. I don't know. I think I covered everything. I say this spiel every time, but we're going to go ahead and get started. And what we're going to do, this is a Q&A. We've got Dr. Coiner here. It'll be just like last time. So you all are welcome to ask any kind of question, anything that you want at all. We had people submit some questions ahead of time, so I have them written down here. We'll start with some of those questions. And if you think of a question while I'm asking these questions, shoot it to me, put it in the chat, and we will go right down the list. And it will be fun. We're going to get all the tea, all of it.
Yeah.
Yes. Okay. Well, I'm super excited. So let me introduce you, Dr. Coiner. I'll let you actually kind of just briefly introduce yourself since some people
Sure.
weren't able to join part one.
Yep.
So go
So
ahead.
Dr. Jack Coiner grew up in the mountains in Virginia, trained at Virginia Tech for medical school, ECU for residency, special certification in minimally invasive gynecologic surgery, do robotic surgery, but full practice gynecology. Relocated to the area in the fall. So just getting the program rolling, getting to know the lay of the land, meet all the folks, and trying to provide some good quality care up here in Boone. So
Awesome. Okay. Are you ready?
I'm ready. Let's
Drum
see where we're
roll.
going.
Okay. It looks like we're starting off with prolapse. So this person said,
Okay, prolapse.
do I need to do anything about a prolapsed bladder? Will I eventually need surgery?
That is a great question. So prolapse is a very common thing, and it definitely earns a spot on this list of things you may be embarrassed to talk about anywhere else other than with your gynecologist. So we can start out with basics of like the mom sneeze where you have to cross your legs every time you sneeze. That can be a sign of prolapse. It is usually just gravity and time, unfortunately. Having babies definitely increases your risk for that, but you don't have to have had childbearing to have pelvic organ prolapse. Couple different ways that you can have prolapse in your pelvis. So the first is a cystocele. So that's the bladder prolapsing down into the vagina. It's like a drop in your bladder. Your grandmother would say that she had a bladder tack procedure. That's where they go in and do an anterior repair. So they basically do surgery to reinforce the front wall of your vagina and kind of tuck things back up. You can have apical prolapse where your uterus is actually falling down into your vagina. I think of that because I'm from Virginia and I have to keep things simple. When you're doing laundry and you're rolling your socks inside out, it can kind of start doing that. So your uterus is falling down and it's kind of rolling your vagina out with it. And then the last type is a rectocele. So that's when your rectum is bulging into your vagina. That can be from obstetrical trauma, but also chronic constipation. So if you're having to push really hard to make a bowel movement, it can create that defect where it starts bulging up. So the first step is never surgery. In my opinion, the first step is always pelvic floor physical therapy. We have several in town. We're fortunate to have them around so that exists here, which, Kegels are the exercise that everybody knows about. So tightening your pelvic floor musculature. Sometimes with prolapse, it's more, think of it kind of like a hernia. And so you can do crunches all day if you have an abdominal hernia, but it's not going to strengthen the defect because the defect's actually in like the tough tissue, in the tough tissue. And so you can strengthen those muscles. It can, make it better. Sometimes if you have prolapse right after having a child, we give that some time to kind of let things, quote unquote, get back to normal
Right.
before we jump right to surgery. Other options would be a pessary. A pessary, for lack of a better description, is like a rubber donut that goes in your vagina, and it just holds the bladder wall up or the rectum down. It just takes up space so things can't fall down. That can be kind of annoying because you've got a rubber donut in your vagina. And so most patients will come in and see me on a 3 to 4 month interval. We have to take it out and clean it off and put it back in. And so then surgery is the other option. So I touched briefly on like the anterior repair. We do the same thing on the back side. We can repair a rectocele with a posterior repair. From a uterine prolapse standpoint, that's something I'll usually do robotically. So we do a hysterectomy, and there's 2 main ligaments that support your uterus. And so if they've relaxed enough that it's allowing your uterus to kind of drop down into your pelvis, we can shorten those ligaments up to kind of resupport the top of your vagina. And we do that surgically. So not necessarily jumping straight to surgery just because of prolapse.
Yeah.
And really, it's one of those things. If I see it during a yearly exam, I'll make mention of it. Like, hey, we kind of got this going on. If it's not causing you any problems, as long as we can still pee and poop normally, we don't feel like we're sitting on an egg. Let's see if we can't get some time before we have to do anything about it. If you come in and you're like, hey, it feels like I'm sitting on an egg all the time, or I'm leaking urine, then we can kind of talk through that. But a lot of that is, form versus function. We can do surgery to kind of tack things up. It doesn't mean that necessarily it's going to help your bladder function any better. We have some other procedures that we're going to start doing. One main one is called a Bulkamid procedure. It's on my list of things that I've ordered. So Bulkamid, from a description standpoint, again, this is just the pointer's explanation of things. It's like lip filler. And so instead of putting it in your lips, we go just inside your urethra and we put a bulking agent in. And so when you cough or sneeze or you just want to stop your stream, you can actually control that better because it's not as hard to like get those muscles to close. We just make the muscles closer together. And for women that works for, it is awesome. So a lot of my, 30 somethings, 40 somethings that are doing the mom sneeze, that is a pretty easy first step where we used to have to do surgery or slings or all kinds of meshes and things. Now I'll try to at least do the bulking agent first. And if we got away with it, it's like, hey, awesome. We get 4 or 5 years out of a simple procedure that we can do in the office. So.
Yeah, awesome. I remember you talking about that when we've gone to different provider visits about the Bulkamid injections. Okay, that's great. So that was our first question that someone had submitted previously. I'm marking it off my list. And you know what?
Right.
Further down my list, we had questions about the mom sneeze. So I
Mom
like
sneeze.
that.
Yeah.
I can mark it off here. Now, are there other symptoms that would lead you to think that you have prolapse going on? So you're talking about the mom sneeze or trouble urinating. Are there any other symptoms?
So you can have tugging or pulling sensations. It's hard because like vague low back pain is like, oh, is that prolapse or is that just my back hurting? And so that's something that you come in, we take a look, do a physical exam. For the exam part, and not to get too in the weeds or terrify anybody, but we take the speculum. And the speculum looks normally kind of like a duckbill. I take it apart and we just do a single bladed exam. And so the speculum's whole design is vagina open. And so it will take away any prolapse by nature because it's holding everything in a position that's not natural. So put in a single blade and kind of hold the floor down, and then we see if the roof's caving in on. We'll flip it around, we hold the ceiling up and see if we have a bulge with some valsalva or like bearing down, and we can see the mobility in your pelvis, and then kind of go from there on. Like, we do everything in grades because we get paid more if we make it difficult, right? So there's stages of prolapse. So a stage 1 is like, hey, it's just a little bit of a drop. Grade 2 is like kind of halfway to the front door. Grade 3 is even with the front door. Grade 4 is hanging out in the hallway. Okay, so when it gets to be a grade 4, we need to do something about that. Okay, a 1 or a 2, I kind of make a note of it, like, hey, this is something we're going to watch. It could get better with age. It could get worse with age. We'll kind of, keep an eye on things if you're not symptomatic. Grade 3 is really where you can kind of make a difference where it's not so advanced that the repair is usually more difficult, but it's bad enough that they're going to feel significant symptomatic improvement by having it repaired.
Awesome. Okay. I want to throw in here for people that have hopped on, just to let you know, we cannot see you, we cannot hear you. So if you have questions, please put them in the chat. I do have a few questions that are coming in through the chat. I'm going to cover some questions that people submitted prior to the health talk. So we're going through those now. We just talked about prolapse, and now I'm going to move on to this next question, and it's on endometriosis. So this person said, for someone with endometriosis, what are the treatment options, and what is the rate of reoccurrence after excision surgery? And will you like clarify what endometriosis is?
Sure. So endometriosis is when the glands that should be inside your uterus, so the lining that's growing and shedding every month, are stuck other places. Okay. And the unholy trinity of endometriosis is pain with intercourse, pain with periods, and pain with bowel movements. You don't have to have all three, but if you do have all three, it's probably endometriosis. Okay. If it looks like a duck and quacks like a duck, it is probably a duck. We don't necessarily have to operate on it to prove that it's a duck. And so in gynecology, we kind of have two hammers, okay? We have birth control hammer and we have surgery hammer. And so with that working diagnosis of endometriosis, we'll tend to tailor our therapy initially at birth control. Because that is a relatively low risk intervention, we don't necessarily have to do a surgery to diagnose that, because it's like, hey, you probably have endo, let's try a low dose birth control pill, or let's try Depo, or something like that is generally how that starts. Okay. As we get more involved, where we've tried some of the easier things, our pain scores aren't coming down, then I'm more inclined to be like, hey, let's look in there, actually confirm the diagnosis of endometriosis. Then at least we know what we're fighting, and make sure we're not chasing a ghost with pelvic pain of unknown origin that we're just treating like it's endo. So that's the quick on endo. The main goal of therapy, so when you think of those glands that are inside your pelvis or other places, every month when you cycle and have your menstrual cycle, when you're bleeding from the bottom, there's something bleeding internally. So those little blebs that are stuck other places will bleed also. Your abdomen does not like having blood in it, okay? And so it will wall that off, okay? It'll make almost little blood blisters. What read about it, powder burns, if you're a big CSI fan. So like when a gunshot wound has like stippling, they can look like powder burns inside your pelvis. That is a classic like endometriosis finding. But because of that, each month when you cycle, that blood kind of refreshes itself. And about the time that things calm down and your pain starts decreasing, you menstruate again. And so the goal of therapy is really to try to limit those menstrual events to get things calmed down. It is a chronic condition.
Yeah.
And so I usually tell folks in the office, if we can, if you're living life with a pain score of like a 7 or 8, if we can get you to a 3 or a 4, like that might be like, hey man, we're doing awesome.
Yeah.
And having realistic expectations that this is something that we're going to have to deal with for a while. A lot of that too, there's no correlation between like the size or the severity of the endometriosis and how bad your pain scores are. So if you have one little spot of endo that's right on a nerve, it could crush you. And you could have a old Goomba, which we call like an endometrioma, a cyst of endometriosis that some women may not even know that they have it. So it's a prime example of life is not fair. And so usually, like I said, we'll tailor the therapy. Like a progesterone only form of birth control is usually the best. If we need to add a little estrogen, we can do a low dose pill and just try to skip as many period cycles as we can. Then if we need to, we go to surgery. So to answer that question, going from surgery, if you have to do it over again, one of my huge pet peeves is when I see a patient who's 26 or 28 and they've been operated on like 3 times. Okay.
Wow.
It's one of those chronic, right? And so if you want an excuse to take somebody to the operating room to go in and save the day, like it's a great reason to be like, let's just keep on going in there and looking around. I don't like to do that. So like initial surgery for like the diagnosis, while we're in there, we try to get out as much endometriosis as we can to give them a fresh start. but you're going to need some kind of chronic therapy usually to kind of suppress things down.
Yeah.
There's fertility concerns always with endo. It can create inflammation, and the scarring can kind of cause some tubal occlusion. So that's something we work up, all the time if we need to, cross that over. But really the therapeutic options is just to try to limit menstrual events.
Yeah. Us women, we have it hard.
You got the short end of the stick for sure.
I know.
Yeah, that's all stuff that
Oh,
guys would not put up with. Like a period, like, we can't handle a cold, much less like this thing bleeds for multiple days every month. Like, yeah, pass.
it's very unfair. It is very unfair. I
But
was thinking
you
about
get to
it.
bring life into the world. Okay. So like that is a
Hey,
pretty
that's
cool trade-off. Like you are the creators of life. That's a pretty awesome thing that you can hang your hat on. So it's not all bad, but yes,
yeah. I
there's a
had
longer checklist of things you have to worry about for sure.
That is very true. Um, I haven't looked at the list of people who are all on this call right now, so there may be some men on this call, but I had a male colleague say yesterday, he was like, "Well, I love the health talks, but I saw like it's another GYN health talk." And he was like, "I didn't know if it'd be weird if I hopped on." And I said, "Absolutely not. It's
The more
educational."
you know, right? I
I
mean, like,
know. And my
yeah.
gosh, come on here and see what all the things
Yeah,
that we have to
yeah.
deal with
No,
as
I think
women.
it would give men a whole new perspective on, things that you guys have to deal with on a regular basis that we don't have to deal with.
Yeah, it's hard. Um, I'm gonna go on to the next hard
All
question
right,
here.
let's go. Keep it
Okay,
rolling.
and I've got people sending me messages and stuff too. I want you to know that
Good.
I see them. I just wanted to get through some of these questions that people had previously submitted prior to the Health Talk starting. We'll jump to this one. So we're going to be talking about some hormone stuff. So this
Okay.
person said, I was diagnosed with invasive breast cancer last year. This is the third type of cancer I have had, with the first one being a mixed nodular lymphoma and having to do chemo before the age of 40. I have been hormone depleted for years. Could I do anything about that now?
So the hormones, we kind of touched on this last talk with like a breast cancer that was positive.
Yeah.
If the cancer is hormone related, then hormones are a big no-no because it will increase your, risk.
Yeah.
If it's non-hormone dependent, then absolutely we can. Okay. That you can call hormone replacement. Hormone replacement and birth control pills have a lot in common. Okay. And so at a younger age, one of the easier things, if we have premature ovarian failure, whether that was a natural like autoimmune thing or through chemotherapy, we just need to regulate estrogen and progesterone levels. And so we can do that with like, hey, here's a birth control pill. Okay. It doesn't have to be any more complicated than that.
Yeah.
If you know that you're going to have to get chemo or radiation that's going to affect future fertility, a lot of times they can try to do ovarian preservation, where they'll actually do egg harvesting and then put them in the freezer for you for a later date when you're ready for child rearing, before they go through the chemotherapy that can affect your fertility down the road.
Hmm.
They're working on some really cool things with that, where they've actually taken like ovarian tissue and implanted it in like forearms, and it keeps the
Oh.
ovarian. Yeah, I know. Okay. So, but they put like ovarian tissue in like as like an implant
Mhm.
subdermally. And I'm talking way out of my specialty here, but like
Mhm.
they're doing interesting things like that, where it's like, okay, well, we're going to irradiate your pelvis or something like that. We can freeze some ovarian tissue. We put it in your forearm and we harvested the eggs out of your forearm, which is like science fiction level stuff. So all hope is not lost. But if you know going into it that you're going to have to get chemo at 23 and you haven't had children yet, I would talk to a
Mhm.
reproductive endocrinologist first. If you can wait, like, hey, let's wait a month to do this chemo so we can do egg harvesting, that would be much better than trying to mop up afterwards. Where if she comes in and we're like, hey, what's my ovarian function? We can do testing for that, hormone levels. There's a hormone level called an anti-Mullerian hormone. I jokingly call it the egg freshness test. It's how many eggs are still left in the carton in the refrigerator. And so we can use that as a fertility risk moving forward, where it's like, hey, there's no more eggs left in this carton. Your fertility rates are, we got to discuss that. Or it's like, actually, you do have good, positive response. So if we do agents that will help stimulate you to release an egg, it should respond positively because there are still follicles there.
Awesome. Okay, we have a lot of questions coming in here.
All right.
I do see one here. This person said, I struggle with low libido. What can we do to help women with that? And I'm going to refer them to our first health talk.
Yeah,
So we talked a lot
yeah,
about low libido in our first health talk.
yeah,
So if
we
you
did.
missed the first health talk, that is available on our UNC Health Appalachian YouTube page, and it's also on our website. So if you were to search Dr. Coiner on unchealthappalachian.org, that will come up. I even typed up answers to some of his questions about low libido. But I highly recommend that you go there. We talked a lot about that in part one. Let's see. We have another question here. This person said, there are a lot of trends out there on habits you can do to cycle sync certain foods or exercises depending on where you are in your menstrual cycle and the hormones at play to help with period symptoms and increase fertility, etc. Is there credibility to this?
So the simple answer is anytime in life that someone is selling you the problem and the solution, your ear should perk up. Okay. And so there are a lot of influencers out there that are talking about products that they're actually being paid to represent.
Yep.
Be cautious there. Okay. I see a lot of natural supplements. There are hormones in natural supplements for sure. Okay. But when they're not regulated by the FDA, it's hard to know how much you're actually ingesting. Okay. So if you're using probiotics or nutritional supplements, they can have enough hormones to negatively impact your cycle when we're trying to help. Okay. Even some like higher level progesterone supplementations that are supposed to help with fertility goals. And they actually, if you give high levels of progesterone, it's just like being on the low dose birth control pill. And it's like, okay, great. This is supposed to help you. But if you're taking it the wrong day in your cycle, it can actually suppress your ovulation. Okay. Now,
Yeah.
that is less tricky if your cycle is exactly 28 days and every Tuesday afternoon at 11 o'clock, here comes your period. Then it's like, okay, you can
Would be.
time things like natural family planning gets a whole lot easier. Okay.
Yeah.
But if your periods are sometimes 32 days and sometimes 27 days, then it's like, okay, well, I'm doing things at specific days in my cycle. Even using period tracker apps, the period tracker app has no idea where you are actually in your cycle. Okay. The part of a woman's cycle that we know for sure is from the time you ovulate until you menstruate is 14 days in everybody in the whole world. Okay. The variation between when your egg starts to develop and when you ovulate is why everybody's cycles are different lengths. The period tracker, when you put in the data like, hey, I perioded on this day, hey, I perioded on this day, all it does is it's mathematically averaging how long that cycle is, and it's just giving you a guesstimate of what day you're on. There's no actual basis as far as what day you're currently on. So I would use an abundance of caution. Now, well-balanced diet, lean meats, fruits, veggies, exercise, rock it out. Okay.
Yeah.
That is for a young, healthy patient. Okay. Getting pregnant should be like falling off a bike. Okay. Because there is nothing physiologically wrong. If there is something physiologically wrong, that's when we can jump in and start doing treatments. But I would caution a lot of my type A, I'm a controller, I make Excel spreadsheets on when I have intercourse and that kind of stuff. You
Whoa.
get a little bit in the weeds, okay? And I don't necessarily think that you're doing yourself a lot of favors there because your stress and anxiety levels are then going up. You're trying to force something to happen that you can't control. And so an abundance of caution would be my 2 cents on how much money you're spending on supplementations and, probiotics and things like that.
And trends that you're seeing.
You got it. Yep.
Whoa. Okay. We'll go on to the next question because we've got lots of questions. So let's see. This person said, is vaginal dryness just a menopausal thing?
Not necessarily. It can be an anytime thing.
Okay.
Vaginal dryness, you will be more sensitive to it as you approach menopause. So estrogen promotes vaginal health. All right. The tissue down there, as your estrogen levels come down, will tend to thin out. Okay. And so during intercourse, what you sense as dryness can actually be a dryness issue, but it can also be a lack of stretchability, okay, or elasticity of that tissue. And so when with initial insertion, it's like what I call death of a thousand paper cuts, because it doesn't stretch like it used to, and you get little micro tears, and that can feel like a sandpaper dryness situation.
Yeah.
So sometimes we can correct that with just some estrogen cream vaginally. Sometimes we do hormone replacement, like orally, where we're doing systemic replacement there. Sometimes it's just a matter of like, hey, we got to call timeout and use more lubricant. There's no shame in that game. There's always time for more lubrication. If it's a just daily kind of event in a young, healthy patient, they make Vagisil wipes for lubrication that you can wipe with. If it's more of a like, hey, when I'm walking, I'm feeling friction, they make a product for that. As far as promoting vaginal health, sometimes we promote like vaginal reacidification. So your vagina likes to be acidic. Different things that are pH balanced can throw that off sometimes. And so we really want to get the good bacteria that are keeping everything in check down there present. And so either boric acid suppositories or douching with like half water, half white vinegar can acidify your vagina. It makes the good, healthy bacteria grow, and that holds everything else kind of in check. That's something that I wouldn't encourage you to do all the time. That's more of a like, hey, if you're talking to me, like we've got an issue, like let's try to do that. The other thing is sometimes a yeast infection can feel like vaginal dryness, where it's like that irritation that women come in and they're like, I'm just dry and irritated. And it's actually a fungal infection that's causing the inflammation that feels like dryness. So.
Interesting. Okay.
Yep.
Okay. Okay. Moving on to the next question here.
Next.
As someone with PCOS at 24 years old, there do not seem to be a lot of treatment options until it is time to conceive. What are things I can do to improve fertility before being ready for children? Sometimes weight loss and birth control feels like the blanket treatment for everything.
That is true. It is an easy answer, right? So PCOS, polycystic ovarian syndrome. I think we talked about this a little bit last time, but like PCOS is when the eggs aren't released regularly. It's usually from the middle part of your ovary making too much testosterone, and it blocks those ovulation events. There's two phases in treatment with PCOS, okay? If we're not cycling consistently, I don't want the inside lining of your uterus growing and growing and growing and never shedding, okay? And so the easiest way to do that is through birth control pills, okay? If I give you a pill, we can get you cycling normally, and so we're not overgrowing that lining, all right? If you don't want to take birth control pills on a regular basis, I have plenty of patients that just don't want to ingest hormones any more than they have to. And in those patients, I'll do like a week of progesterone to basically trigger a withdrawal bleed. So if they go more than 2 or 3 months and they're like, hey, Coiner, I haven't seen a thing, we'll do like a week of progesterone and stop it. And that'll be enough to kind of trigger a washout period. And then we'll kind of see if things come back online. If you're heavier set, okay, the fat cells will make increased estrogen levels. The increased estrogen can trick your brain into thinking that there's already an egg there, okay? And so I have a significant number of patients who, through diet and exercise, were not having a period because they were heavier set. They lose weight, their estrogen level comes down, and then all of a sudden their ovaries are functioning totally normally. And so it's not just a blanket statement of like, yeah, diet and exercise, do that. It can actually reverse it. We have a cutoff for most fertility patients. Most clinics use kind of a BMI of 40. And so if your BMI is above 40, they won't take you on as a fertility patient because they're caring about their numbers looking good as far as how many people they can, be successful at getting pregnant. What you'll see though is if you come in with a BMI of 45, not having periods, and like we're talking about doing fertility drugs, they dedicate themselves through diet and exercise, their BMI gets low enough that they're under the cutoff then for drugs. A lot of times they don't need them because they're ovulating already just because of the weight loss. And so there is something, physiologic to that. As far as a PCOS standpoint, you lose eggs at the same rate whether you're ovulating or not. It's one of the unfair things in life. You would think that if we put you on pills or you took ice baths or something, we could slow down the rate of cell death. The eggs, whether you're releasing them or not, are going away at the same rate. So there's not really any fertility preservation with PCOS. It's more menstruation regulation. And then when it is game time, most of the drugs that we have for PCOS are just to encourage ovulation to happen on a consistent basis.
Mhm. Mhm. Someone just chimed in and said, I can attest to this statement. Someone who was 360 pounds wasn't having a period but once a year. I lost 100 pounds in 2021 and got pregnant with my son without even trying.
Yep. And that happens, we see that so much on people who have had like gastric bypasses or sleeves and they weren't menstruating at all. And like one of the things they harp on so much when you have that is like, hey, please don't get pregnant until you're done with your rapid weight loss phase. And it is solely because of that reason. It's like they get their gastric sleeve, they're dropping weight like crazy. All of a sudden their ovaries come back online and they didn't used to have to, use protection because it was like, I'm not ovulating, I can't get pregnant. And then it's like, oh no, you did get pregnant and during your rapid weight loss phase. So I mean, there's a huge piece of fertility. And likewise, you flip it. Okay, so go to the skinny minis that are cross country runners that can run from here to Wake Forest and back without stopping. They don't ovulate normally either. Okay, because their body's like, oh my gosh, we're getting chased by a lion. Why is she running so much? We don't need to procreate. But I
Yeah.
need to regulate her period too because she has so little estrogen in her body that we need to add that back so she doesn't turn into a sweet little osteoporotic, 31-year-old. So,
Well, okay.
yeah.
Um, okay, let's see. I think I've covered all the questions that people have submitted here, so
Okay.
I can go down my list of questions. And these are actually questions that people have said to me or were from my team, or some of them were my questions. Okay, this is actually one that I've really always wondered myself. Um, if you were on your period, should I still go to my scheduled gynecology appointment?
Sure.
I've always wondered that.
Uh,
To me, that doesn't
that
feel
is,
comfortable. I
no, I
personally
get it.
will
That is
cancel.
totally up to your preference. Okay. I promise you that if you have a gynecologist that is scared of a menstrual period, you need to find a new gynecologist. Okay. You have to do worse than a little bit of blood to freak us out because we have seen all kinds of stuff. Now, if you're mortified at that thought, okay, then just reschedule. It's already awkward enough. Like, I promise we don't care. But if it bothers you and you feel better not doing that on your period, great. Now, there is a little validity to if we do a pap smear and you're on a heavy flow day and all they
Mhm.
see on your pap smear is blood, it increases the likelihood that they're going to say insufficient sample. And it's like, great, I'm glad we went through that for no reason. That
Yeah.
usually is not the case. And that would only be on like, day 2 or 3 where we're super flowing would be
Yeah.
more of a likelihood than like, hey, my period's kind of on its way out, or hey, we're just getting, started. So
Got
I would say that's personal preference. Now, there are some hormonal fluctuations with breast tenderness for a breast exam and things like that, where it's like, hey, I would just rather do this at a different time. Not a big deal at all if you want to schedule around that, but also not a big deal if you're like, dude, I'm off on Tuesday and I'm coming to see you. It's like, cool, we'll deal
Yeah.
with what we got.
Okay. A question that kind of piggybacks off that question.
Yep.
Do I need to shave or wax before my appointment?
Gotcha. Absolutely no. I'm just kidding. No, I will promise you, your gynecologist cares much more about clean socks than any kind of pubic hair situation that you have going on. Okay.
Got
No, there's actually quite a bit of benefits to having a more natural state downstairs. Okay. It is a natural protectant for you from getting hit. It also will wick moisture away. And
Mhm.
so if you're a member of the Bald Eagle Club, you can be more prone to like fungal infections. Um, Between waxing and shaving and yoga pants, it's like the arch nemesis of vaginal health. Okay. So we take all the hair off and then we saran wrap them and they can't breathe. So that's where I kind of default to like your Mimi had it right, putting a house dress on as soon as she got home, and just letting everything air out. So if you're wearing your yoga pants, you go get your Starbies, come home, shower, cotton underwear, nothing crazy. Okay, we need some air. But yeah, definitely not for your gynecologist. If your gynecologist cares about your pubic hair situation, you also need to find a new
I know
gynecologist
gorgeous.
because
Got
if they're
it.
that involved in your situation, that is a line that should not be involved. So no.
Okay, now I have another question kind of
All right.
picking back off of this. Um, when you're saying like just air it out down there or whatever, are
Yep.
different types of underwear better for your vaginal health than others?
Sure.
So I'm
So
talking about like different fabrics. So like cotton
Yeah.
versus, I don't know what all the other fabrics are,
Yeah. Yeah.
or like thongs
Right.
versus, I
Yeah.
don't know.
A lot of that is like, it depends on, like, if it's something you're struggling with, right? So it's like, hey, we're chronically having vaginitis. It might be like, yeah, let's try to address that situation. A healthy vagina should be able to walk through fire without blinking. Okay. But if
Okay.
we're struggling where it's like, I'm like right on the edge of like, is there going on? That's when I'm like, hey, look at some of those easy things just to see if there's something easy that we can address. Okay. So
Mhm.
from the gynecologist standpoint, like cotton, like jockey granny panties would be what I would pick for you to wear. Okay. Again, none of my business, but like the ability to wick moisture away because physiologic discharge is a thing. Okay. And so if we're in some kind of crazy, silk get up or lacy get up, we don't have a lot of absorptive capability. And so we can create inflammation from the rubbing, and then we have a moist environment. Sorry if you don't like the word moist, but we have a moist environment that can promote irritation. And so it's like, yeah, you kind of did that to yourself. Now, I understand if you come to the gym, you don't want to wear your jockey panties with your stretchy pants, but when you get home, swap them out.
Awesome. I really like the quote that you said there, and I can't exactly remember what it was, but what did you say? A vagina should be able to walk through fire or something? You should
Yeah,
like,
without blinking. Yeah, a healthy
yeah.
one really. Like that's where, and a lot of times I call it the vaginal seesaw. And so, you come in, you have a little irritation, then we give you diflucan and we kill all the yeast and then the bacteria grow. And then you got a little funky. So then you come back in and we give you antibiotics and then we kill all the bacteria. And so we're like on this never ending like whack-a-mole, and
Yeah.
really vagina should be able to put up with a lot. It's just when we're in this like, hey, she's a little upset, it doesn't take much to upset her again. But
Mhm.
that's where we try to promote vaginal health, not just treat disease, right? It's
Yeah.
much better if we can prevent things from happening than having to treat things once they've already happened.
Mhm. Crazy. Again, this is a lot. Us women, we just have a lot.
That's a lot. That is a
It's a
lot.
lot.
Yeah.
Okay, we've got some other questions on here that we've had people submit.
Okay.
Okay, are you ready?
I
If
guess.
you are a perimenopausal woman that had a hysterectomy but got to keep their ovaries 14 months ago, and you
Okay.
now feel like you need help with hormones, what does that look like, and what should women do first to start that journey?
Yeah. So come and see me. That's an easy.
Make
Thank
an
you for the
appointment with Dr.
underhanded pitch
Pointer.
there. Make an appointment with Dr. Coiner. The hormone replacement in that situation. Okay, so when you have a hysterectomy, we take out the thing that hurts and bleeds. Okay, they leave your ovaries. So hormonal functionality is still going to be the same thing. So what she's going to miss out on, and I say that facetiously, is the weird periods that can happen around the time of menopause. All of the crazy hormonal fluctuations she will still get to experience just like her sister. She's just not going to have to buy pads or tampons at weird times because she doesn't know when it's happening. So if we do hormone replacement in that situation, it actually makes my job much easier because we don't have to worry about protecting the inside lining of her uterus. So in hormone replacement, estrogen is kind of like everything good about being a woman, in my opinion. So if I could give you unopposed estrogen, meaning no progesterone, just the estrogen piece, that's like, hey, you get to eat the candy and don't have to worry about the wrapper. Okay. If you still have a uterus, we have to do progesterone. And that's like, okay, that can kind of be the evil stepsister of some hormones, but we have to do that to balance out the estrogen component. If you don't have a uterus, we can do unopposed estrogen. It makes hormone replacement exceedingly easy because it's like, hey, we just have to find the dose of estrogen that makes you feel good. We don't have to worry about the progesterone piece.
Yeah. Okay, awesome.
So,
We had
yeah,
another
come
question.
in and talk. Yeah, go ahead.
We had another question about this person said, has he discussed the topic of I need to get my hormones checked and what's his thoughts on this? And we did kind of
That's a
cover
good
that
video.
in part
Yep.
one as well. Wasn't that one of the, was
Yeah,
that one of our first questions in
yeah,
part one?
yeah. That the perimenopausal thing kind of leads right into that too. So
Mhm.
I will let you in on a trade secret. Okay, hormone replacement is almost always I feel statements. Okay. So if you come in and you're like, I feel this way, I feel that way, we
Mhm.
fix that with hormonal replacement. Okay. Laboratory evaluations sometimes have a place, and sometimes it's a very good excuse to draw lots of labs and help me pay for my boat, because your hormone levels are always going to be different. So if I draw your estrogen level today and I draw it in 2 weeks, I could get different results because of where you are in your cycle. That is a totally normal physiologic thing. But if I wanted to use that as justification to try to mimic what your hormones, quote unquote, should be doing in the background, that is a very slippery slope from a manipulation standpoint, where it's like, are we making money or are we actually helping people out?
Right. Let's see here. We have more questions. Okay. So this person said, can we go back to the PCOS question?
Sure.
I think what's lacking in the conversation about PCOS is that it's more than just weight and infertility issues. For example, I can't exercise my way out I can't exercise my way out of unwanted hair growth. Other than
Yep.
medications like birth control or spironolactone, or metformin, what else can we be doing?
Yeah. So the tried and true, okay, if you got diagnosed with PCOS in 1994, they would put you on spironolactone and metformin before you left the office. Spironolactone is intent is to decrease free testosterone levels. Okay. It affects your kidney though. And so it makes me a little skeptical if you're like 21 and healthy that we put you on spironolactone for your entire adult reproductive life. Like, what is that doing to your kidney function later in your life? Okay. The metformin is from an increase of insulin resistance with PCOS. And so I I'll check to see if we have signs of insulin resistance, at which time I use metformin. I do not knee jerk to using metformin. Okay.
Mhm.
The birth control pill will decrease hirsutism. That's the doctor term for I can grow a mustache. Okay. So it when I give you estrogen, it increases something called sex hormone binding globulin, which is, I'm going to use a Harry Potter analogy. It's like the cloak of invisibility. Okay. So the testosterone is still circulating in her body, but sex hormone binding globulin binds that free testosterone up so it's not hitting receptors and causing facial hair growth. Okay. In
Mhm.
my opinion, I'm killing two birds with one stone then, because I want a regulator period like we talked about, but I can also decrease her mustache just using the birth control pill. And
Mhm.
so I don't like when I see, a healthy 22-year-old that comes in with PCOS that's on metformin, spironolactone, and oral contraceptives. It's like, you're working on your sweet little old lady med list at, in your 20s. And some of that I think you don't really need.
Mhm.
You are not going to be able to exercise off your mustache. She is exactly right. That is what in our first talk, we talked about like our type ones versus our type twos. So the exercise lifestyle modification is more for the type two, like, hey, I'm heavy set and my ovaries don't work. The type that we haven't really been talking about is like a type one, which is like you have a primary ovarian dysfunction where your ovaries making too much testosterone. You can be insulin resistant. You can have the hirsutism. You can have a velvety black line on the back of your neck. Those are all things that we need to test for then. If you have an elevated hemoglobin A1C, it's a test for like a pre-diabetes kind of test. Then absolutely you do need metformin to bring that value back down and sensitize yourself to insulin. Endocrine disorders like a primary PCOS all travel in groups. And so it is not uncommon that you have a touch of thyroid disorder. Oh, my pancreas doesn't work great either, and my ovaries are kind of off. The interplay amongst all those symptoms that can get kind of challenging to treat, each little thing. That's where meeting with an endocrinologist, or especially a reproductive endocrinologist, if you've already had multiple opinions and multiple trial runs from a GYN, like a basic GYN, it might be time to be like, let me go see an endocrinologist, let me go see an REI, and like kind of talk to an expert in that field on what we should be doing.
Now, I know you have been here for a few months now. Where's the closest reproductive endocrinologist
So
to
Wake
us?
Forest or Charlotte.
Okay.
Yeah.
Ugh.
Yep. So we're starting to do some of that stuff up here, but again, that's like, infertility evaluation and treatment. If we're getting into like harder to treat endocrinopathies, that's where they come into play, where it's like, hey, it may be worth And that's not something that you're going to have to drive back and forth for multiple appointments. That would be like a consult. Hey, I drove to Charlotte. I saw the endocrinologist. This is the therapeutic approach that we're going to take. And you may not see them again ever. Then, like, they can set the recipe for your PCP or your, regular gynecologist to be like, hey, I met with Dr. Smith in Charlotte. This is what I'm doing for that. And they can be like, great, we could just keep on going about the same playbook. We don't have to reinvent the wheel.
Yeah. Okay. We're at 12:45. Can you believe it?
12:45. Bam. Just
The
like
time
that.
went by. I know. And I still have so many questions. It's like blurring it out, but I still have so many questions on here. My gosh, we may have to do a part 3 at some point, but I'll give you a break. I
Or
won't.
people can just make an appointment one-on-one. Then they get me isolated all by myself and they can hear my analogies firsthand. Yeah.
That's exactly what people should do. Well, thank you so much, Dr. Coiner. You know how much I adore you, and I really, really appreciate you doing this with me for 2 months in a row now.
2 months in a row. Yeah. Oh, it's been great. I enjoy getting the word out, and I think it's important to talk about stuff like this to people that you can trust, and you have to have a therapeutic relationship, especially when you're talking about sensitive. The part that I love the most is just the relationship building and getting to partner with people. You need somebody that listens, and if I don't know the answer, I'll make something up or I'll get you to somebody that's smarter than me to figure it out. So anyway, it's been fun. Thanks everybody for joining us.
Thank you so much. And then for everyone, as you hop off, you should receive a survey that asks you about the health talk and what you want to learn about more health talks, or if you have other questions for Dr. Coiner, I'm happy to pass those along to him. But please complete that survey and be on the lookout for our next health talk.
All right.
Thank you, Dr.
so much.
Coiner.
Bye, everybody.
Thank you so much, everyone.
Bye-bye.
Bye.